Hi, good afternoon, everyone. I'm actually presenting this on behalf of the lead author who was unable to attend, so that's another way of saying be gentle with me on any health economics questions, because I didn't do the modelling. It's also, I've also come from Switzerland, as was said, and it's exactly my bedtime now, so I'm not at my best form. But anyway, we'll get into the presentation. Earlier initiation of ART, is it cost effective? Some of you may be thinking that this is a bit of an anachronistic question, but I think it is good to remind ourselves that it wasn't that long ago. It was only 2 years ago that a number of countries in sub-Saharan Africa were still stuck at a threshold of CD4 200 for initiation of ART, and it was only in 2010 that the WHO guidelines made a clearer recommendation, and even then it took several months for countries to come in line. And as has been said by others at this meeting, CD4 is the reason for that is effectively a rationing approach to ART delivery, given the concerns about the higher cost of treating more people at higher CD4. And that was definitely expressed even after the WHO guidelines came out by some major donors who remained reluctant to fund the efforts of countries to shift to a policy of earlier initiation. So the objective of this study, well, this is the scientific phrasing of the question, but for me, a more leading way to frame this objective is simply, is waiting until people fall sick before giving them antiretrovirals a good way of saving money or not? Now, the methods, there have been other cost-effectiveness studies of earlier initiation. This adds to those because it uses programmatic data. It was from the TasP cohort in Uganda, cumulative total of 26,000 patients on ART over an 11-year time period. And we calculated the incremental cost-effectiveness ratio expressed as cost per life year saved from the perspective of the Ugandan Ministry of Health, a number of sensitivity analyses, and we assessed total costs of earlier initiation, including inpatient and outpatient services, ART, and treatment for related opportunistic infections over a 5- and 30-year period. Here are some of the parameter inputs. A number of data were drawn from the literature, but they were all based on data from Uganda and a number from the TasP cohort. The cohort data that we included were principally survival data over an 11-year period and data on incidence of tuberculosis at different CD4 thresholds. The results, the model generated ISAs for a 5- and 30-year time period. At 5 years, earlier initiation had an ISA of $695, which is considered to be cost-effective per life year saved. And over a longer horizon of 30 years, it was considered to be cost-saving. But there were variations in the sensitivities to program costs and the discount rate, particularly at the longer time frame, because we only actually had data for 10 years, so the estimates become more fragile as you go further on. And that's mentioned in this slide. The data is based on a maximum of 10 years of reporting. Considering survival as the only clinical endpoint limits the potential benefits under consideration, obviously. We could have inputted more information to try and further estimate the benefits of earlier initiation, and the study would have been enhanced by a full cost utility analysis if detailed information on costing quality of life was available. Issues such as absenteeism from work, the cost of caregivers in caring for the sick, and lost productivity in the workplace would have all added additional benefits to this model. Existing shortage of trained staff will prove to be the main bottleneck in the system, because while it is proven to be cost effectiveness and it's reassuring to the Ministry of Health of Uganda that they went for this policy, having spent several years deliberating whether it would be more costly or not, the actual question is whether the service can provide for that additional number of patients. It's worth noting that in 2009, when Uganda was at a threshold of 200, ART coverage was around 53%. When they moved to a threshold of 350, the coverage fell to 39%, which is an indication of the additional need that was reflected from this, the change in the threshold. But of course, the trade-off is you're dealing with a less sick population. And I would just note there that this has very much been the experience of MSF. We work in a number of countries in Southern Africa, and during this period we worked in countries that had gone for earlier initiation, 350, Lesotho and Zambia, and countries that had not done so. And our operational experience was very much that the benefits of treating a less sick population are reflected in health service efficiency gains. Task shifting is greatly facilitated by that, of course. So the conclusion of this is that earlier initiation is cost effective, confirming data from previous studies, including studies from South Africa that use data not from clinics but from derived from estimates in the literature, and the HAART trial also published cost effectiveness data. It's great to hear that some of the treatment as prevention studies have got a cost effectiveness component, and that's going to be reported soon, because in the case of Uganda we're obviously reporting this data as a reassurance to the MOH's policy change, but it would have been nice if this could have come earlier and sped up the policy change. As we know, ART represents an opportunity to both reduce new infections and reduce mortality in specific populations, and increased access to ART, it should be noted, must compete with other cost-effective interventions that the Ministry of Health must choose from. The pressing question, and it's been alluded to here, is that's all very well, but how do we then get people into care earlier to reap the benefits of increased survival and cost effectiveness of enrolling people earlier? And this is just a leader to the session which will take place on Monday. It's a study from Kenya, and it's looking at the CD4 at entry into the clinic according to different modes of testing, and it shows that patients who are tested at the home are arriving at care at a much higher CD4 than those who are getting an HIV test in a clinic setting. So there are potential solutions to that question that many have been stuck at, which is it's all very well to treat people earlier, but when the baseline's so low, it's an irrelevant thing. Well, my answer to that is that we need to find those models to get people into care earlier if we agree that there are benefits to doing so. Going forward, there are a number of, this is just off the top of my head, and I think you've been invited over the course of this conference to think of other data that is important to gather, but clearly the clinical and cost benefit above 350, good to hear that 052 will be coming out with that data. We need to have it as soon as possible. Specific co-infections, cost effectiveness at higher initiation thresholds for people co-infected with Hep C, malaria, and perhaps other co-infections, and the cost effectiveness of earlier initiation of specific patient groups that are being entertained by WHO and others as potentially eligible for immediate initiation, such as older age or older children. And the cost effectiveness, including the prevention of TB at high CD4 and treatment as prevention. Thank you for your attention.